Explore psychedelic assisted psychotherapy, but also the intersect with ceremonial medicine, and just really holding those models, those ways of working with this medicine closely throughout this presentation as Bianca and I explore the realms of preparation, integration, and the clinical and ceremonial space. So let's just spend a moment dropping into this time together. I'm sure many of us have had really busy days today. And if you feel like it, you can close your eyes with me here and just, dropping into this Zoom space as we acknowledge incredible community that's growing in Australia for psychedelic medicines, and really calling in the wisdom of this country, of the elders that have held these lands long before we've ever arrived. Just acknowledging their connection to country, to totems, to the elements, to the dreaming. As we think of Australia, we might want to remember a place that is really special. If you're ever feeling disconnected, that you can go to. It might be the beach, might be the bush, your home, countryside, somewhere that you can visit, or call into your meditation space if you're needing to feel into our country. Tonight, just holding these sacred medicines closely as they rapidly move around the world, the clinical space, and we have so much to learn as we try and bridge the science and the sacred together. Awesome. So we'll introduce Bianca in a moment, but my name's Dr. Lani Roy. I'm a social worker and psychologist at the Signs of Life Psychology. So it's a private practice that I've run. I opened it when I was 22, so many moons ago. And it's just been incredible to see it grow over the years, and now really being a bridge and having a platform to really support and sustain the mental health and psychedelic ecosystem that's emerging in Australia. So I run a lot of student placements, social work, biomedical, psychology, do therapy, research and assessment, and ally and partner with PRISM, which is Psychedelic Research in Science, Entheogenesis Australis, an Australian Psychedelic Society, also Enlightened Mental Health. So working closely with those organisations to really see how we can support these medicines into our ecosystem in Australia. And I've got a real huge passion for working in complex trauma and sexual abuse. Worked in child sexual abuse for about 15 years, and I've been really privileged to see, the huge potential of these medicines with clients, and instill a lot more hope in that there's a real opportunity here for people to heal potentially quicker, and also be able to activate their own inner healing potential themselves. And also fluent in sign language, so love doing sign language and just working with kind of really diverse cultures and populations. So just as mentioned, my ethos is really to advocate for psychedelic therapy through evidence-based advocacy, promote spiritual awareness, but I think it's really important, the transpersonal and existential realms that can be really neglected in mainstream mental health settings. Why are we here? What do we do with this mystery in the short time we have? How do we process our trauma whilst we have so many obstacles and challenges around us? And how can we connect to the natural world through ecology and building sustainable relationships in this field?
So I'm Bianca. I'm a psychologist here in Brisbane. So I also work mostly in the complex trauma and dissociation space. I'm also an EMDR practitioner. So I've also got a special interest in working with Aboriginal and Torres Strait Islander peoples, and did my PhD in the area of Indigenous psychology. And at the moment, I also work providing supervision and consultation to other psychologists that are working in the dissociation space, and especially with dissociative identity disorder, as well as working in harm reduction and integration support for people that are working with non-ordinary states of consciousness. So that does include plant medicines as well.
So today we're going to have a look at the classic psychedelics, the psychedelic-assisted psychotherapy model, as well as touching on ceremonial processes and I guess the benefits and limitations of these different models. We'll look at integration and how we can promote post-traumatic growth or really stabilize the view, stabilize the benefits of the medicine through integration. And we'll also touch on a little bit of history and just what's happening around the world, just to give you the overall context of where we're at in Australia at the moment. Okay, next slide. Yeah. So I just want you to keep in mind that although many psychedelics are illegal in Australia, just need to acknowledge that these medicines have been used for thousands of years around the world in different contexts. And although, you know, we adhere to the laws in Australia, we also need to be unpacking from a critical perspective the impact of colonisation, the impacts of the medical model, and also that different countries have different contexts and laws that are right for their setting. And we're seeing a huge push for legalising psychedelics in Australia through decriminalisation or through the TGA, trying to get them rescheduled. It's just holding the complexity here that many people seek out these medicines for relational means, for example, MDMA to connect with friends or with a partner, for somatic reasons such as cannabis treatment for deep release of somatic trauma, for celebratory means such as rituals, as equinox and solstice, people all over the world coming together to use these medicines in sacred fire and circle, and also therapeutic context in the clinical setting, psychedelic-assisted psychotherapy, and creative means. Many people using these medicines for art, for music, for poetry, and philosophical inquiry, for eudaimonic exploration. And I really like to just acknowledge and respect all these different perspectives, and that there isn't a privilege with the clinical model. It's the model that we're going with in Australia because that's what makes sense for us in this context, but it should be unpacked as we will throughout today's discussion. I thought I'd just put these incredible photos in to just highlight the difference of you know, the clinical model which is emerging at the moment, which is typically a psychiatrist and a therapist, such as a psychologist or psychotherapist in a room with a bed and an eye mask, typically for 6 hours taking the medicine. Whereas, as you can see, medicine has, is that right, Bianca? It's moved. Oh. There we go. Yeah, as we can see, medicine is used in such ritual and celebration in tribes and communities. Next slide. And again, just acknowledging that laws are socially constructed depending on the social and political context that we're in. And I just invite you to maybe consider tonight, do we have the right for a sovereign mind? Do we have the right to pick a mushroom and explore consciousness? Or is this something that the state should be able to intervene on? Should people be sentenced or charged for personal use of substances? Where do you stand on these important issues? Because this is what's happening in Australia at the moment and around the world. Do we have freedom of consciousness? Do we have the inherent right to be engaged in plant symbiosis? Or is this something that needs to be policed? And our current cultural context, is neoliberalist, it's capitalist, it's a medical model typically, which is in a stark contrast with the shamanic model. And I guess tonight, as we hold both those tensions, do we have the right for freedom of consciousness? We also need to really highlight in both of these settings the importance of the setting and the skill that can hold the container to produce the best outcomes for clients. And that's done within the harm reduction paradigm. Next slide. I'll just briefly go through this. We know that these medicines have been used in ancient times and in ritual. There's ancient paintings of psilocybin found in Europe and North Africa from 4000 BC, indigenous cultures in North and South America, the Aztecs consuming what they called the flesh of the gods, and documented potentially in Catholic texts for peyote uses, which was coined witchcraft in Europe. So there's a rich history out there of these medicines, and not new. It's just new to us. Next slide. And it was used in ancient Greek, in the Elysian Mysteries, kykeon, a drink and a process that the ancient Greek cultures used, such as Plato, Socrates, Aristotle. And these mystery schools are known for their rites of passage. And again, another concept that I want you to hold tonight is that whether it's in ceremony or the clinic, when people engage in altered states of consciousness, it is often a rites of passage. And many people... Sorry, I'll just make sure everyone's on mute. Naomi, can you go through the list? Thank you. Next slide. And maybe, Bianca, do you want to speak to this a little bit, just from your perspective, Indigenous perspective of psychedelics? Is there anything you want to say about this?
Yeah, well, we know that Indigenous cultures worldwide have been working with these medicines for tens of thousands of years, and have very, strong relationships with plant kin, and for so many diverse uses and ceremony, medicines, all of the above. And I think that concept of plant kin here is really important. It's building that relationship and right relationship with these medicines. And I think in the Western context, and here in Australia in particular, it's going to be really important and a challenge to create or work to create the cultural container that can hold these medicines as well. And I guess as we talk more about integration and that concept, to support people in the integration process, because with Indigenous cultures worldwide, there is that cultural container that's already set to really hold and facilitate the full benefit of working with these medicines and plant kin.
Yeah, and we were talking the other night about, in this field in Australia, everyone talks about integration. You have to get integration after psychedelics, and it really hit home to me that we need it, because we are disconnected from the land, and we need to pay a therapist to help us integrate our medicine experiences. Whereas in the jungle, there's community elders built in to the community. They don't need to pay a separate therapist. They've got their community. They've got they're living in connection with the land. There's less talk. That they often laugh at us at the thought of integration, because it's like it's not perceived like that. They might go to their local shaman for discussions and wisdom, but it's just normal. It's just part of their culture. So it just shows that the difference in the models and our society, and to be cautious, because we are still placing a lot of emphasis on the medical model, when there's many models occurring around the world. Thanks. Yeah, so I guess in Australia, really exciting time. There's been huge grants being administered to different universities for trials, and we know that there's going to be looking at psilocybin for anorexia, I think even CBD for anxiety disorders in youth, DMT for depression. There's a lot happening at the Melbourne Monash Institute with MDMA, assisted psychotherapy, also looking at social anxiety in young adults with autism spectrum. So you can see the Australian government has acknowledged that these medicines have potential, and hence the grants and lots of potential for philanthropic and other projects emerging. I'm really excited to be, soon to be working on very different trials from breastfeeding mothers to Ayahuasca community groups to other psilocybin trials. So there's a huge diversity in trials occurring. Next slide. Yeah, and as around the world, we are seeing expanded access schemes in different countries where they're changing the scheduling so that psilocybin is more accessible, seeing that happening in places like Israel, Switzerland, Oregon being the first state to legalize psilocybin for therapeutic use. And yeah, just rapid growth and change occurring around the world. I think it's going to be really interesting to look back in 10 years from now, at this point in history and see the growth and what's occurring. Next slide. Yeah, so we have, I'll just briefly mention these, and then in the next slide, I'll probably go into a little bit more nuance about the medicine. So we have synthetic medicines such as LSD, derived from fungus and grains. We've also got MDMA, which is an empathogen, ecstasy it is known as, but in the trials it's this pure substance that really opens the heart and works on shame and helps reduce fear in the amygdala. Great medicine for relational healing and talk therapy. We've got ketamine, also synthetic drug. And I'm really excited. I've been doing a little bit of legal ketamine work in Australia, and just the potential for, it can be helpful for depression, but also for people who've experienced sexual trauma. They're able to dissociate from their dissociation and actually feel what it's like to be safe, and to actually their internal network, their system, for different parts to come forward. This is where internal family systems is really conducive with things such as ketamine and MDMA. And yeah, psilocybin, which we know, the fantastic fungi. And we've got ibogaine, which is or iboga, an African plant, and it's often used for addiction. It's a much longer medicine, up to 30 hours. And mescaline, which is one of my favorites, San Pedro, which is a cactus brew, and huge potential there, I believe, for again, it's similar to, it's got some crossover between like an MDMA and LSD, but it's used in ceremony, often in a teepee by fire, and it has, I believe, huge potential for relational healing as well as trauma and attachment issues and sexual trauma as well. And peyote, which is, it's much more revered medicine in the sense that it's really culturally often inappropriate to drink peyote. They believe, I'm no expert, I'm speaking on this, but when you drink, you are drinking their ancestors, and it has much stricter conditions in which you can drink the medicine, and something to be considerate of when you are engaging in psychedelics. Is this approved by the culture that it's originated? And we've got DMT.
On that peyote, I might say as well, it's also incredibly endangered. So that's a big issue at the moment for the Wixarika tribe, because they can't even engage in their, annual pilgrimage to harvest the medicine, because just the farming, highways, all of that, the natural, their natural pilgrimage pathway is just now being decimated. So yeah, it's pretty frowned upon for someone that's not a member of, say, the Native Indian Church or the Wixarika tribe to be consuming peyote.
Yeah, And do you want to also speak to, we haven't got it on here, but the 5-MeO bufo, similar kind of some challenges there with cultivation.
Sure.
Yeah.
So there's also 5-MeO DMT, which is different to DMT, and it's quite a very different experience as well. So 5-MeO DMT is the secretion from the Bufo alvarius toad, which is found in the desert in various places in Mexico and some places in the US as well. And so it's a very short-acting experience. And so they're also looking now at some clinical trials for the use of 5-MeO DMT in treatment of depression, etc. Because well, you should, generally about 15 minutes, maybe 10 to 15 in the peak experience, but about half an hour-ish to come to. So there is that benefit of it being a short-acting medicine in a clinical setting.
Great. And yeah, and we've got DMT and ayahuasca, but we'll talk a little bit more in depth as we move along. Next slide. So MDMA, and many people are familiar with this from, I guess, the party scene, but MDMA in the clinical trials is very different. It's typically a much lower dose, so there's no chance of that serotonin dip or that come down the next day. It's held within the therapeutic space of preparation and dose and integration, and it has huge potential for addressing attachment wounds of different attachment styles of abandonment, of anxiety, disorganized. When people come to MDMA and they feel safe in their body and they're able to talk about their trauma experience and have it be witnessed and held by the therapist, there's a huge potential for that to be stabilized in their relational world if they continue with the work. It's not just about that dose session, but what comes after that. And what I love about MDMA is that it often gives people the chance to narrate their story again from a safe place. And often when they go back to the trauma memory afterwards, there's a softening. The memory has been kind of re-encoded, almost like a shredding and re-encoding. And it has that, for many people, like a softening and a warmth around it, often held by compassion and empathy. And that's because of the downregulation of the fear response. Many people in the, I guess, not in the clinical space, but in other spaces use MDMA, a little bit of MDMA before they do psilocybin. Again, there's no clinical trials on that at the moment that I'm aware of, but for some people it can help soften the body, feel love and safety and empathy before they then journey off into the astral. So I definitely think we'll see combinations of this in the trials to come.
Yeah, it's a really incredible medicine for assisting with like a nervous system reset, and really, for people that are either in that sympathetic arousal or that dorsal vagal shutdown, to actually access that ventral vagal state of safety and connection.
And to be able to talk about potentially sexual abuse and not feel shame in that moment. Because of the MDMA moving through your body, and what they found in the MAPS trials again is that I think it was nearly 70% of participants spontaneously talked in parts work on MDMA, even if they weren't, told about parts. So it actually unlocks, parts of your psyche, of your system, quite safely for you to be able to explore with the therapist. Next slide. Yeah, and as I mentioned, ketamine, it can be used in lozenges or IV, nasal spray, and it is one of the few psychedelics that can be potentially addictive, and it needs to be monitored a little bit more closely. For some people, there might be some complications with liver or long-term use, but in the PAP model, in the ketamine-assisted psychedelic model, it's typically the model I've been working with is 6 sessions across 2 weeks with prep and integration. And again, what we're seeing is almost like a fast-acting antidepressant, gives people the capacity to alter their state of consciousness, get out of the rumination, the bleakness, the void, have a break from it. And in that break, when you've got that window of opportunity, that's when the therapy can really, there's movement and there's this capacity to see different perspectives and step out of your mind and step out of your trauma story. And again, really, really conducive for sexual trauma as well as parts work. Next slide. Yeah, that's okay. We can hand them out in the. I guess it's traditionally used for pain management. It's really interesting how many people have gone to ketamine pain clinics, had ketamine, but haven't had any psychological support around it. You know, it's so common for people to have had this medicine in the medical model, and they're dissociating from their bodies, and they're going home without that psychological support. So this is where we're really seeing the huge opportunity for the psychological and transpersonal realms to really be able to support the medical model as well for those gaps, because it's not just about the physicality, it's the energetic and spiritual realms that are open up when people take a dissociative such as ketamine.
Yeah, just on that, I think it's really important that people going in for pain treatment are aware that there's this psychospiritual element to it as well, because in my work in integration, I've certainly had people come after, not going for ketamine assisted therapy as such, but purely for pain treatment, that have had a lot of phenomena arise that they weren't prepared for or expecting, and that can be very distressing. So even without that intentional ketamine assisted therapy intent, it can still certainly bring up a lot of stuff for people.
Yeah. And yeah, a medicine that I work really closely with, I've got Dr. Jamie Ricord on my team, who's there's a really great webinar on my YouTube channel that he's done on CBD and THC and homeostasis. So I really recommend people listen to that, particularly if you've ever had a cannabis history, or if you're thinking about medicinal cannabis use, or you're supporting clients to consider this, because there is so much most people don't know about these oils and these medicines. And I guess, we only discovered in 1995 that we have an endocannabinoid system. So our body actually benefits significantly from CBD. Most people can benefit from it. THC is obviously a little bit more, needs to be more specific and with caution. But what I found with a lot of my clients is if they're wanting psychedelic assisted psychotherapy and they can't get it yet because of clinical trials, or they're not willing to, go overseas, or for whatever their reason, it's a good introductory process to help them with their dissociation, to help them to develop a healthy relationship with the plant medicine. It's legal, and there's experts in Australia that can support you with that. And it's often used in to support with PTSD. For example, the Somatic Institute in America, Saj Ravi, has a big body of work around this, where they've used cannabis before psilocybin to help people's nervous systems prime for the psilocybin, because sometimes it's too shocking, for example, to give a soldier with complex PTSD high dose of psilocybin. It's too much for the nervous system, and you can actually dissociate from psychedelics and not feel anything. It can happen to a whole range of different clinical populations. So CBD really can help the system soften and be ready to meet other psychedelics. In saying that, some lineages, for example, work with cannabis. So there's ayahuasca lineages that it's a big part of their prayer. It's ayahuasca and cannabis, whereas the ayahuasca lineage that I work with, Vegetalista lineage, it's no cannabis and CBD. So you can see that even there's cross-cultural nuances, not just medical model nuances that are existing out there. And I guess there is caution for people say, with bipolar and mania with cannabis, but many of my clients have a diagnosis of bipolar and mania and complex PTSD, and these are microdoses. This is medically controlled, and if they work with it consciously and have a relationship with it, I've seen it work really, really well. So it is really about that case by case nuance. Next slide. Yes, LSD. What can I say about LSD that you may not already know for people who've explored it? I think, like anecdotally, clients are finding if they've got autism or a neurodiversity, that microdosing or LSD is helping them open up socially, and that's why there is trials looking into LSD and adults with autism, because it can really help people to, I guess, their fear response, their anxiety, their social perceptions can really open that up with cognitive flexibility and creativity and freedom of expression, and huge potential for other conditions such as anxiety, depression, PTSD.
There's also some studies happening at the moment where LSD is showing a lot of promise in both microdose and small dose for chronic pain conditions. So that's really exciting to be following that, because there's a whole range of chronic pain conditions that they're looking at there with LSD as well.
Yeah, and anecdotally, many of these medicines women use during premenstrual psychosis or just PMS. Again, we don't have the literature on it, but there are women out there in the community microdosing small amounts to help support with mood regulation. So it's interesting that these medicines, which are inherently disrupt the psyche, can be used in small doses to help potentially ground the psyche and regulate mood. Mm-hmm. Do you want to speak for a bit, Bianca? Psilocybin? Jump in.
Sure. Well, psilocybin, I'm sure, is one that most people have come across, or with Michael pollen and the pollen effect, as they call it. And some of you might have seen the documentary on Netflix. I know that Lani and I's inboxes have been inundated since that's come out. Just people really interested, particularly in psilocybin. So very commonly referred to as magic mushrooms, and one of the most heavily researched medicines at this point in time, especially for disorders of control, so things like OCD, anorexia nervosa, and depression as well. So psilocybin breaks down that, turns that default mode network offline. So that really rigid, ingrained pattern and way of thinking, and creates new neural connections between brain regions. And so this allows for increased cognitive flexibility and new ways of thinking and perceiving in the world. So that's why they're showing a lot of promise in disorders of control, and in particular depression. They can really act like a reset button in the brain. And they were introduced to the Western world in the 50s by Mexican curandera, Maria Sebben. And I think in particular psilocybin is where we really have to be engaging in reciprocity and reparations for the Indigenous knowledge systems that we're drawing upon in this Western model, because the story of Maria Sebben is very sad in terms of her regret for showing the Western world the child saints, the magic mushrooms, and I guess the consequence of her bringing that to the Western world.
Yeah, well put. I love people celebrating her birthday. She was on social media last week going around, and her quote saying, "You are the medicine." And the ayahuasca that I work with often says, "You are the medicine, and the medicine is you." And it's just, I guess, a little tip for those entering altered states of consciousness. When you can start to operate from that space of you are the medicine is you. It's that symbiosis, it's that relationship. It's not you've taken a trip and all this stuff's happening to you. It's you're connecting with nature, and you are nature, and you're moving with it. And it can be less scary when you take that perspective of that dance and that symbiosis, as opposed to the phenomena happening to me.
And this image in the slide is just an incredible brain imaging scan that shows the increased neural connections between the placebo brain and somebody using psilocybin. So it's pretty incredible that neurogenesis as well is why psilocybin is also being researched in terms of potential Alzheimer's treatments as well, which is really exciting.
And again, we'll just briefly move through this mescaline, which is San Pedro or peyote, and it's typically really quite a long medicine. It can be up to 12 hours. For example, Wachuma, San Pedro is in a brew, and there's different states of contraction and expansion throughout the 12 hours. It's typically held in ceremony with music, with ikoro, which is song and prayer lines from different tribes and lineages, and also served with other medicines such as rape. It's like a tobacco kind of a mix that people put up their nose that is said to kind of activate meditation, deeper meditation spaces. So there's other cultural practices and tools that are used alongside these medicines to help people if they are contracting, and then if they're expanding, and definitely through song, through rattle, through rape, through different scents and feathers, and weaving with the elements such as wind and water and fire. Next slide. Just a little photo that we did from me and Melissa's post-traumatic growth after sexual abuse and psychedelics course, and just acknowledging all the incredible women who journeyed on that course. But as you can see, the power of altars and ceremonial spaces, and many people that go on the medicine path do end up creating a deeper relationship with altars and meditation spaces as living beings, not as something that just is there in their home, but something that they go to, they feed, they connect with, they pray at. You can see my little 2 French bulldogs, I caught them, as I say, praying at my altar one day. And I love this quote: "If you want to keep your fire burning, leave your offering on the altar. She's intentional." And I think holding that dear as we move through the model tonight of, if you want to keep the magic of the psychedelic journey, the healing properties of it burning and alive, you've actually got to have a discipline. You've got to have a practice. I guess, mystical experience by its very nature, as William James once said, it often fades into the light of day. And a big challenge with psychedelics is we have these experiences and then they disappear. So how do we bridge that? How do we make the most out of our medicine? And that's being intentional and keeping that fire burning. Next slide. And again, we'll just probably move quickly through this so we can get to the model. But my favorite is ayahuasca, shamanic brew, 2 plants coming together to make incredible magic and activating DMT. And it's typically used again in sacred ceremony in the dark, or in other traditions such as Santo Daime, which is like a Catholic religious church in America and other countries where it's legal. Very different from my lineage. My lineage is in the dark at night and in silence, unless there's singing by the community members. Whereas the Santo Daime, there's prayer, there's movement, there's dancing, and it can occur in daylight as well. So it depends on what lineage you're working with. Very, very strong medicine, and Psyche Institute is going to be really leading the way in Australia with kind of different versions of ayahuasca in the clinical space. So really excited to see what they come up with. And just also acknowledging the Dietero space, which is the Dieta space, which is the lineage I'm part of, and that's the 10-day processes where you typically have 10 days of no salt, no sugars and fats and oils, basically just rice and vegetables, and 5 24-hour fasts. And you sit 5 days with a master plant, and then you have multiple ayahuasca journeys, and It's a very deep cleanse. It's very physical. It can be very physically demanding. There's a lot of time on your own, a lot of silence, and you connect in with the master plant. Not just ayahuasca is there, but to support you to connect with the master plant. And then there's also the integration phase afterwards, which normally lasts about 2 weeks or a month, depending on what plant you diet with. And in those processes, there's additional kind of discipline that you've got to hold, or try your best to hold when you return. So no touch, and restrictions on food, and you're very open energetically. So you've got to kind of adapt your environment when you get home to be able to help the medicine land and then integrate back into society safely. Excellent. Do you want to speak at all to DMT? I think we've covered that enough.
Yeah, so just quickly, DMT, there's this NN-DMT, which is quite different to 5-MeO DMT. It elicits a very different experience, but same thing, it's very short acting when it's used on its own, rather than say in as part of the brew of ayahuasca, like Lani was talking about. But been showing a lot of promise in the treatment of depression as well, and tends to have a same thing, about a 10 to 15 minute period of activation. And so again, really good at breaking thought patterns and new ways of seeing and perceiving, and typically elicits quite a spiritual experience. DMT is actually referred to as the spirit molecule, and 5-MeO DMT is referred to as the God molecule. So that's quite indicative of what these experiences and the mystical experience that can go with these medicines can be like.
There's a great article I'll try and find where they looked at the data of, because a lot of people that have DMT experience phenomenologically entity experiences, and there's a really brilliant article that tracks the different types of entity experiences. So many people report the entities knew them, were waiting for them, wanted to know why it had taken them so long. Some entities were indifferent and kind of wanted them to move on. And so it's just a really curious article. Regardless of what your perspective is, it kind of holds up from a phenomenological perspective, where we don't know why or how or the mechanisms behind it, but the relational component with the journey and the entity is fascinating. So we might just keep moving on to the model, if that's okay. And I'll briefly mention, there's not a lot of data on these sort of studies, but how I work with people personally, particularly looking at childhood attachments, what type of attachment do you have, and what medicine are you going to use, and is that going to exacerbate your trauma or soothe it? So for example, if someone comes to me with a disorganized attachment style, they're quite don't have a good sense of self, they might have some borderline processes, I potentially wouldn't be, encouraged, not that I'd be encouraging, but I would be, if they wanted to do something like ayahuasca or bufo, it's like, well, you've got a disorganized psyche and a disorganized attachment style, and then you're going into a very big medicine that could be very, disorganized. So there is a stepped position that you can kind of take, which could be safer, such as CBD, THC, MDMA, mescaline, and, just working your way up to those higher realms, because it can be very damaging for people who are already disorganized to go into disorganized spaces. And but I guess on the flip side of that, people who might be very avoidant, if they are able to dissociate from that, from their ketamine, they can get a sense of release of fear and possibility. If people are anxious and are able to be safely held in the container of MDMA, or safely held in an ayahuasca journey, the deep sense of courage and bravery that can be instilled in people after those medicines, can really help those attachment wounds. So it's just something to think about clinically, is what attachment style what the medicine could do. Could it help or actually hinder that? Next slide. Yeah, so psychedelic assisted psychotherapy, it really is that combination of the therapist, the relationship of the therapist, the trust, the rapport, the respect, the holding of the client, and the preparation, dose, and integration. And unlike other medications, which typically, suppresses symptoms, psychedelics helps people to go outside of their window of tolerance safely. So, it is very different. We're actually encouraging people to let go, to break, to cry, to become dysregulated, for cathartic releases, for somatic releases. But there is that the trust and the holding of the medicine and the therapist. And also, as we will talk about later, the prep and integration, the metacognitive skills that the client will start to learn so that they can stabilize these altered traits into altered states, and trust that opening of that window of tolerance and that disorganized mind and dysregulation, there's actually a huge body of science and healing that's occurring that actually makes that worth it. And I guess that's the difference potentially with some of these medical model approaches of mainstream medicine, is because there is that deep kind of release and that process, that cathartic healing, and then the changing of the chemistry and the state-based change, and then the relational component of the therapists. Next slide. So just briefly, some of you may be very familiar with this. So the model is all about preparation, which is the sessions before, and the skills that you help the client to embody and stabilize, the dose, and the integration phase. And for some people, preparation could go for years. In the community, it might be they want to do psychedelics, but they're not ready yet. So could they explore altered states of consciousness that don't involve substances? A lot of my clients, they make the goal that one day they're going to do psychedelics, but they're not ready. So they look at drumming, they look at trance, they look at ecstatic dance, they look at holotropic breath work. They start to build trust in altered states of consciousness and trust in letting go, and then the skills of integrating those spaces and working their way up to the high doses of medicine. And integration becomes a huge piece of work, a piece of its own, a real magical piece of its own, when people really see the fruits of discipline and of staying connected to the medicine in bringing non-ordinary states into the ordinary is really important. Next slide. It's going to cough, bear with me. Yeah, so this is one of Melissa's slides. So just shout out to Melissa, one of my partners in Psychedelic Wonderland, and she puts together these incredible often slides just really outlining the states, the pivotal states that people go through when they go through psychedelics. So they might have the problem, the challenge, the chronic stress or the mental illness, the acute stress, the pivotal mental state, the psychological change, and then state change. So what does it mean by that? It's that psychedelics can open up to different states of consciousness that give us greater flexibility and mind enhancing, and makes us more sensitive to context, more sensitive to our unconscious. And it gives us the capacity to change deeply held schemas and beliefs and disrupt the psyche, disrupt our cultural conditioning, how we've been raised, what we've been told to believe. In parts work, we think, voices, we may have internalized the voice of our abusers, of our family, of our culture. And through the dose session, this can all be disrupted. And there's huge opportunity for a window of opportunity to rebuild. And Trail once said to me recently was, we get the opportunity in psychedelics to engage in the symbolic realm. So that's in myth and legend and play and imaginos, and we get to disrupt our story. But unlike any other medicine, we have the opportunity in those days to follow to re-author our story. And what story do you want to tell? And that's where the therapist can come in to really hold the client. What story now do you want to tell about yourself? Next slide. Just briefly, particularly given there's been a bit of disrupt in the psychedelic space. Many people may have watched Four Corners recently. I just want to acknowledge it was really quite a challenging show to watch, not only because I was on it, but just the way the scene was depicted, and just acknowledging that there are, even though it is illegal, there are very talented, incredible alters and community members all around Australia and around the world that do this work really well. So it's not just the clinical model doing it well. There are community members doing it well, but there is also a dark side of psychedelics, and that was shown on Four Corners. So it's just been really cautious about, and this can occur in clinical, of course, in clinical spaces, as we saw on the show, as well as the community or the underground, as we say. But if your client is looking for a guide, or you are, it's really important that the facilitator, be really cautious of narcissism, of spiritual bypassing, of self-aggrandizing behavior, any concerns with cult behavior or sexualized behavior. There's no place for this in this sacred work. It's the medicine, the guide is meant to be a neutral conduit for the medicine to move through you. And that requires a huge amount of skill to be able to be grounded, to be self-reflective, to have a huge range of contemplative practices. The client needs to be able to trust this person, to be able to, trust their body and their psyche, to be able to be open and vulnerable. And that requires a huge amount of skill. So please do your homework and help clients to consider this stuff. Unfortunately, there's still a lot of people going to their therapists. Therapists are saying, I can't endorse or encourage this, so I'm just going to shut down this conversation, basically. And it's a real risk to our clients. Have the conversation. It's harm reduction. Make them feel comfortable about who are they talking to? What does it look and feel like? Is it safe? Because there's no shame in any of this, and people are being shamed. And the medical model is scared. They're scared of the law and liability, but I'm more scared of someone not getting the education and making a really poor decision.
Absolutely. Yeah, and there's with that particular shutting down of the conversation, I think this is why preparation and being and supporting clients in preparation is the harm reduction strategy, because I have a list of potential questions for people to take to a prospective facilitator. And in my experience, I have had more clients then decide that they're not going to go ahead with a psychedelic journey than actually decide that they were going to, because for various reasons, maybe they have decided that they didn't have the space in their life to really fully embrace a good preparation and integration process, or they didn't think that the facilitator had the necessary skills to support them. So by virtue of actually supporting them with the preparation, they've then, we're actually reducing the number of people that might be considering going into an experience that could be unsafe. So I definitely think there's scope for preparation in the harm reduction space.
Yeah, so psychedelics is really a turning point in the life journey where major change simply must occur because the person is unable or unwilling to continue in his or her present course. It is a point of desperation, a breaking point where something has to give, and it does. And it is just highlighting that, and I certainly was there myself. I might put my journey in the notes. Just many of these clients, these people have tried everything. They've tried everything. Something has to change, and this is where altered states of consciousness really can step in, because sometimes we need to get out of our mind, to really reclaim our bodies and reclaim our story. And, we have to monitor the conservative culture of risk versus the level of suffering, and, those topics of freedom of consciousness and right to choice in healthcare. Yeah, so just briefly, there is this assumption that we have a single mind. And for many people, we can get stuck in a part for many years. It might be a depressed part, obsessive, addictive, whatever it might be. But the reality is we are a complex and multifaceted beings. We have a multiplicity in our mind. And, healthy multiplicity is knowing when to be in the right mind at the right time. And what psychedelics can help us do is open up to our parts and our internal family system framework, but also open up to universal consciousness and phenomena, and having a deeper symbiosis with the multiplicity of phenomena that is available to us all. And for people who are experiencing existential anxiety or facing death, or have, experienced religious trauma, being able to open up to phenomena beyond yourself and the larger mind is, incredible. We might just get to the model. Yeah. I think I mentioned that the self is a narrative. So psychedelics gives us the opportunity to explore archetypes, images, symbols, plants, energies, entities, and how can we stabilize this phenomena. It is by having skills to be able to make sense of the narrative, to be able to tell our story, to be able to ground, and what does this psychedelic content mean for me now that I've come home from the clinic or come home from ceremony, what can I do with it? And if we don't have these skills, that's when people can become very fragmented. Yeah. So just highlighting a metacognition. So it's thinking about thinking, and it really is helping your clients to become aware of their thoughts, feelings, sensations, energies, behaviors, being able to observe their parts, be able to observe their story, and through more skill, be able to keep a thread of self while they're journeying in the medicine as well. And often that comes with not just 1 or 2 time use, but people who stay on the medicine path are able to develop these skills so that they're able to keep a thread of self in them while they journey out into different maps of consciousness. And people who have deficits in metacognition are more likely to have mental illness. So attachment issues, rumination, OCDs, BPD, poor reflective functioning. So when you are assessing people for preparation, it's really looking at where are they at with their metacognitive skills? Can they reflect? Do they have any sense of self? Can they monitor their body sensations? Can they reflect? Can they ask insightful questions? So you can't really progress to the dose session if you don't have some evidence of these skills, because it's dangerous. Again, you can't disrupt the psyche if you don't have a mind that's going to be able to come back and reflect on it and talk about it. And that's why schizophrenia, schizotypal just personality disorders are potentially dangerous for medicine. Yeah, do you want to add anything to that, Bianca?
No, that's all good. Yeah.
Slide. Yeah, just the relaxed beliefs under psychedelics. The Rebus model is prior beliefs are more flexible and open to change, which is fantastic because it means that we're open to change, to flexibility, to disrupting schemas and cognitive biases, but it also means that we're open to vulnerability. So for example, if someone is having a peak experience, they feel safe, and their guide actually was to be sexually inappropriate or kiss them or touch them, what can happen in this moment is that if that is the first time they've ever felt safe, then they can attach that abandonment wound onto the guide, and then this guide gets this kind of God complex in a sense of this person I never felt this safe, I've never felt more in love with, and it's very dangerous. And this is why there's a huge I guess need for education in the community about boundaries, about ethics, about safe practices, because that window where the mind opens up is actually the most sacred place, the most sacred place. And clinicians, guides, shamans are meant to be, conduits of that safety and revere it, not interfere with it and hurt it. So just something to think about in your own psychedelic maps. That window, is it being held with deep reverence? Okay, so just take you a little bit through like an actual example of a model of psychedelic assisted psychotherapy. Some of you may know this information, but this is like through the MAPS trial. So typically they do a lot of assessment, a lot of exclusion and inclusion criteria, psychological screening, biological screening, cardiac markers to make sure people are safe. There's a lot of codes of ethics and informed consent, and 3 preparatory sessions, typically about 90 minutes each, and then 3 MDMA therapy sessions, about 8 hours each, then 9 integration sessions, 90 minutes each, and there's typically 2 therapists, male and female. In the trials, the videos are recorded, but again, as highlighted on 4 corners, there was an error there with some of that inter-rater reliability in the trials potentially not being monitored as safely as it could have. So I just want to again acknowledge that the clinical model is safe, but it's also can be flawed, and just as a ceremony, it can be safe or flawed. So just really holding those tensions there. And just why we're looking at MDMA as being one of the first medicines to roll out through the FDA and the TGA is that it is clinically, from like a medical perspective, very safe, but it also is a medicine that can really instill safety in clients, and particularly with PTSD, like no other medicine. And the huge rates of PTSD in our society, and we know that antidepressants, are just not cracking that issue. And I have huge hopes for MDMA entering our mainstream setting, because it is it's clinically safe, and people aren't thrown into the astral. Maybe Australia is not just ready for that just yet. They're dropped into their heart, they're dropped into their body, and they're dropped into the relational space.
And I think it's important to really distinguish the difference between MDMA and ecstasy, because in the media in particular, there's a lot of reference to ecstasy being used as a potential medicine, and MDMA as the pure molecule made as it is for clinical purposes is very different to ecstasy. So I think it's important to just highlight that significant difference that's not well explained in the media.
We might just, I'm cautious of time and want to have some Q&A as well, so we might just keep flicking for a moment. I'll just mention there that the phase, just go back to the last slide, Hunt. Sorry, the phase 3 trials with MAPS with MDMA, that the participants on average had PTSD for 14 years. So this was quite complex treatment-resistant PTSD, and I think it was, so 67% of people that had the treatment, had MDMA, no longer qualified for PTSD up to a year later, and then 88% had clinically, meaningful reductions in symptoms. So, this is serious data that needs to be really acknowledged and celebrated, because, imagine your caseload, imagine if that was the data change in your patients. So huge potential here. Next slide. Keep going, that's okay. I think we've talked about the risks and contradictions a little bit, but obviously there's some in the community, some people with bipolar do take psychedelics, of course, but they tend to take psychedelics in a depressive cycle, not in a manic cycle. And if they do, there's a lot of education in the psychedelic space where people don't do ceremony late at night, which could then trigger sleep deprivation, which could trigger an episode. So there's specific I guess, adaptations that can occur in ceremonial spaces in the community where people who are typically excluded from trials are using these medicines safely. However, of course, that requires a lot of education, community support, and discipline. And for other people, who may not have those skills or those metacognitive skills, it can be, quite dangerous. Particularly, there's SSRIs and, ayahuasca, for example. So SSRIs, which can result in serotonin shock, and also, I guess, large states such as people who have already got psychosis then entering DMT realms or bufo realms can be very disruptive.
Mm-hmm.
I think I said before you dissolve your ego, you need to have one. So that's something to keep in mind. Yeah.
Definitely.
So great integration starts with great preparation, and it's just as clients journey through, just really helping them to build a toolkit, a medicine skin, a medicine toolkit of contemplative practices. It might be journaling, artwork, time in nature, body embodiment practices, helping them to learn to drop into their breath, to be able to sit in their skin for an hour. For some people, sitting in ceremony or sitting in the clinic for 8 hours, if they've never done that before, very, very traumatic, just being forced, by the medicine to sit. So there's a lot of work you can do before that to scaffold that experience, through meditation, through non-medicine related altered states of consciousness. And so really get a real, kind of assess the client's skills, interests, hobbies, practices, metacognitive capacities, their health, nutrition, a real comprehensive map, and what areas can be strengthened, and what tools can then be used to help scaffold that opening, so that that window of tolerance can be held not just by the therapist, but by their own cognitive skills, and then their own medicine bag, as we call it.
Mm-hmm. In the preparation phase as well, despite the fact this is more around integration, I also like to assess their community connection as well. So what supports they have available in the community for when they have completed a journey with a non-ordinary state. Are they connected to others that are doing this work, or are they aware of any community integration circles, those kinds of things? Because whilst one-on-one integration with a therapist is helpful and beneficial, as I spoke to earlier, this concept of a cultural container to really sort of facilitate the ongoing integration and in the community sense as well, because connection to self, other, and community is a huge aspect of these experiences for many people. And so in that initial preparation stage, I like to work through them what their connections are that they will be able to draw upon in this experience as well. All right.
Can I just say, before you go into this, Hun, I might just mention what often people, I use the analogy, and I've picked it up from someone else, but when people go in for open heart surgery, they typically put a lot of planning in place. They don't necessarily go back to work the next day. People often look after them, give them space. They take time to heal and recover. So psychedelics can be open heart, mind, body, spirit, soul surgery. In shamanism, we use the word the doctoring. People can experience like a doctoring, doctors, meaning the plant spirits, entities working on their body, opening it. This is big stuff. So it requires, big planning and big prep and integration work.
So I'll speak to the concept of intention setting when we're preparing to work with plant medicines on ordinary state. So this can really help us to clarify what's drawing the client towards doing this type of work and what they're hoping to gain from the experience. This is because intentions can help to act like an anchor. So that's something to focus on and come back to in order to ground the client during any challenging moments, or to create some context in the integration phase as well, because sometimes it might be, really, inapparent initially, the content of the experience and trying to make sense of it. But if you've got an intention to come back to that sense of why, why am I doing this? What brings me here? That can really help to facilitate that exploration in the integration phase as well. So revisiting the original intention can be a way to frame the experience and to help to further explore and understand the nature of the experience and any of the insights that might arise. So ideally, you want to have a balance between using the intention as an anchor, but not holding on to it so rigidly that it interferes with the natural unfolding of the journey or the process as well. And so in order to set the intention or start to explore that why, what brings me here, why am I feeling called to do this work, some self-inquiry and looking at one's values and priorities might be something to journal on or start to consider in this phase of setting an intention. So people might consider if there's any areas in life where they're feeling stuck, or is there something that they're hoping to move towards, what their values are and whether they are or are not embodying them at the moment and why that might be. Are there any areas in life that might benefit from some increased intention or awareness? Or are there any questions that the person has or something they'd like help with or like to learn about themselves? So some example intentions might be to look at a present day experience with a positive focus. So asking the medicine to show me the joy of being. Maybe if there's something that they'd like to work on, they might have the intention of asking the medicine to help me to see or show me how, those kinds of things, or help with understanding the cause of something or to process something that may remain unprocessed. So asking the medicine for help to be able to work through something in particular. So that's just a few examples of what an intention might look like, but having that anchor is really helpful in making sense and also getting through some of the more potential challenging moments of an experience as well. And so our intentions can support the integration process by providing that real starting point. But like I said, we don't want that balance. So we're not holding onto it too rigidly and trying to direct the experience too much. The other thing is if we really hold on to that intention too fiercely, we might have an expectation that the experience needs to unfold in a certain way or produce a certain outcome. And so people can be quite disappointed if it's not too clear or apparent, or the experience didn't, stick exactly to the intention they went in with, particularly if it's a pretty challenging or big question that they have, because there's so many different types of experiences. You can, and even with the same medicine, sometimes you might have a big, powerful experience, very intense, very somatic. Other times it might be quite low in intensity or even a bit boring or dull compared to what the person might have been expecting. Other times it might be a really beautiful, blissful, joyful experience, and other times it can be incredibly challenging. So we really want to be able to, some people say surrender to the experience. I prefer to use the term to allow for the experience to unfold in the way it's going to, without attempting to direct or force the experience to go in a certain way. So sometimes we say in this space, we don't always get what we want, but we get what we need. And that might not always be apparent in the initial experience or the direct aftermath or early phase integration of the experience, but maybe a couple of weeks or a couple of months later, that lesson or that insight might come where it's like, oh yeah, okay, I see, I can see now. So we want to manage, expectation versus intention. All right.
Yeah, we probably have to move to questions now-ish, but I guess just, setting and skill. Actually, go back to the last slide, hon. I'll just mention, so knowing what's set, what are you bringing to the journey, your mindset, your body, the knowledge of the substance, your personality style, your values, it's everything you bring to the medicine, then the setting, how is it going to be held, and what is going to best suit your client or suit yourself, these different ways of doing medicine, and then the metacognitive skills. And really, metacognition helps people to develop grit and resilience and the ability to self-regulate, and interoception and somatic awareness. And that's really what needs to be stabilized in the whole process as tools to help navigate expectations and intentions and the dose. Next slide.
So just in relation to set and setting, some things that in the preparation phase to consider about the set or the person's mindset is, do they have something in particular they're wanting to work through or explore, or are they hoping to escape from something or looking for an external solution? There are things to really consider where the person is at in that moment, what their current emotional state is. So, for example, if there's been a very significant adverse life event that's happened just before they plan to go into ceremony or participate in a trial, then might need to consider if that's really going to impact their ability to use all their skills in an experience, or maybe it might be a better option to postpone having that experience. And do they have the capacity to create enough space in their life for the integration? If they go to ceremony on Saturday and think you're going to work on Sunday, then that might not be, there might not be enough space to really consider doing this type of work at this point in time. And setting, just again, being the support system who will be present, what medical or emotional supports will be there or needed. Are you familiar with the environment that you're in and had an opportunity to adjust and get to feel comfortable in the space? And setting can also include things like music, pillows, blankets for comfort, a journal, art supplies, anything that can help facilitate a sense of safety. Some people, that's going to be in a really nice, comfortable indoor space. Other people might feel really suffocated and claustrophobic in an indoor space and feel much more safe and held outside in nature. So that's really specific to the individual.
And just highlighting that people with neurodiversity, such as autism, may not like certain smells and sounds. And if you don't know that beforehand, I've met clients that have been really traumatized because they've hated the sound journey, the sound healing journey, because of their neurodiversity and what they needed in that moment. And also highlighting, it's really quite unsafe for anyone to be doing psychedelics if they're in a family violence relationship. So the Maslow's hierarchy of needs with psychedelics is, a safe home to return to. And even if your home's safe, but, it might be your partner is anti-psychedelics and is going to give you a lecture when you get home, that still has an impact. Yeah, like people are so sensitive and so open. So, part of the planning is, can you stay somewhere else where you're going to be supported, nurtured, encouraged? Just making sure that home base is not going to send you back into a contraction straight after the medicine. Just in a nutshell, with integration, it's really important the first couple of days after the psychedelic experience that you don't rush too quickly into wrapping it all up in a nice bow and trying to make exact meaning out of it. The first part of it is the pre-narrative stage. It's staying in the body, journaling, artwork, voice work, allowing yourself to still expand. And then the days and weeks that follow, then the meaning making, the cognition starts to come in. But if you bring in the ego and bring in the mind too quickly, then it shuts down that pocket of flexibility where you can still be expanding and still be enjoying, the fruits of the medicine. So it really is, allowing yourself that time before bringing it. We had many more slides to talk about nature and nature-based practices, but I think next time we need to make it 2 hours, 2.5 hours. Is there any questions? You can pop your hand up, anyone?
I had a question. In the slides when it talks about integration, I think it was it stated that there was 9 integration sessions when it comes to MDMA. Is that the same amount of integration sessions that would be required for any psychedelic use, or just MDMA itself?
It depends on the model and depends on the funding. For example, ketamine, the ketamine model we're doing now is not that many sessions.
Okay.
Yeah, so I guess it depends on the clinical protocol and the funding as well.
And those 9 sessions are, you have to keep in mind it's 3 dosing sessions. So typically it's a dosing session, 3 integration, another dosing, 3 integration, final dose, 3 integration. So it's whereas in the community, how many integration sessions is how long is a piece of string?
Yeah.
Question about microdosing for people with schizophrenia, schizoaffective disorders. I guess I'm not aware of any literature on it. I do know clients that have successfully microdosed. I guess we don't really have any measures. We've only got their qualitative feedback and the subjective experience. But these are often clients that have done a lot of therapy and have some reflective capacity. And yeah, because microdosing can still be really, even if it's small, it can still be really big for some people. If you've been holding on tight and you have a little bit of mushrooms and then you remember your trauma, that you don't need a lot of medicine for a lot to happen. So I guess it's a case by case basis. Any other questions?
I do have a question. First of all, I just want to say thank you for your wisdom and knowledge, Bianca and Lani, for the presentation. That was awesome. The question I have is about the Indigenous kind of community in Australia in the psychedelic space, and how are there any efforts to kind of integrate the Indigenous communities into this space? If you could speak to that for a bit.
Yeah, so, with Indigenous use of plant medicines in Australia, we know Aboriginal and Torres Strait Islander people have a deep and enduring relationship with plant kin, but for the most part, it's also very sacred and protected knowledge. So there's not a lot of documented use, but that's not to say that there isn't. So for example, in Central Australia, we know that there's acacia had many different uses, both medicinal and other uses. And then there's the patchouli bush as well that is known to have psychotropic components to it as well. And so with the current proposed models of psychedelic assisted psychotherapy, there is a real concern that the models aren't culturally safe or accessible. And so I'm actually part of a working group at the moment that is with various other Aboriginal and Torres Strait Islander practitioners in this space that are working to build a model of culturally safe psychedelic assisted psychotherapy for people that may wish to access treatment in more of the clinical space. And, we have high hopes. We're just having a few negotiations at the moment of working with acacia being a plant that already there is that deep relationship with for many cultures. So yeah, there is some movement happening in that space, and maybe Lani wants to talk about your work with Kit as well in that space.
Well, it actually led me to something not controversial, but I guess just that the reality is there are Indigenous people in Australia drinking ayahuasca with white people. You know, we forget that happens too, and I know it does. And these are multi-faith, multi-race communities drinking ayahuasca, and Indigenous people are part of that, and the Adaki, the judge is played in ceremony. So I also think we've got to be absolutely, yes, everything you've said, Bianca, but also there are, Indigenous Australians that are integrated in Australian ayahuasca circles with white people, and beautifully. So I think that gets left out of the discourse as well.
Yeah, and I guess I'm more talking to the current clinical model as well, because I was having a meeting the other day, and even as we were discussing this, and for myself, I was thinking, God, this isn't even a model just for Aboriginal and Torres Strait Islander people. We had this hope that it would be accessible to anyone as well, because we were thinking about the things we would change in a preparation and integration process compared to what you see in current models. And I'm sitting there thinking, well, I would much rather do that too. Obviously more of that nature-based, those kinds of things, which really hasn't been incorporated into the current clinical model. You tend to go into the clinic, you do your preparation sessions in the room, in the clinic that you're going to be dosing in, and then you do your integration sessions either there or online, those kinds of things as well. And so I'm just speaking to the clinical model at the moment for anyone that may wish to access treatment in the clinical way. Yeah,
absolutely. And so Kit Klein is a student of Master's social work student of mine, but she runs an advanced diploma of nature-based therapies, and together I'm also going to be on a charity that she's forming, a health-based charity, and a big part of that health-based charity will be plant medicine research and nature-based programs and retreats. And she is also part of the Science of Life and helping my clients and my students expand our nature-based and culturally diverse platform. She's got beautiful Indigenous children, and she's Native American descent, and just very lucky to have her at the Science of Life. So just getting started with all that stuff. Lots more to come in the coming months. So thank you. This is the first time me and Bianca present together. So I think that went really well, but we definitely had much more we could have covered. So feel free to reach out to us as well if you have any questions. We're very Google us, we'll pop up. Our names are out there, and it will take me about 10 days. I'm just about to go away for 10 days, so I won't be able to get the notes and bits and pieces to you until then. So just hang tight, but we'll send some stuff out. And unless there's any last minute burning questions, we can head off.
There, Emily, do you have your hand up?
Can't see it.
There's someone with a hand up.
Yeah, sorry. Me. I was just curious, with everything that's kind of happening, Bianca, in terms of the treaty movement, do you think it will become, I suppose, easier for Indigenous Australians to push forward with psychedelics because of the rolling landscape of them finding a voice more? Do you think that will interconnect? Or
That's so interesting. And my genuine answer to that is I have no idea, because just in terms of the psychedelic space itself, having a lot of hope, but also really no idea as to how this is all going to look or unfold, let alone for Aboriginal and Torres Strait Islander people as well. So my genuine answer to that is I have no idea.
Thank you. Hope to connect again. There's lots on in this space, so stay tuned. Lovely to connect.
Thank you.